Hello and welcome to our latest installment of the In Conversation podcast. Today's is a special episode in the Fighting for the Soul of General Practice series, and I'm very pleased to be joined by my regular co-hosts, Drs. Rupal Shah and Jens Foell. And we are in turn joined by the eminent Dr. Austin O Carroll. Welcome to you all.
Thank you.
So, for anyone who isn't familiar with the format, each episode, we three invite a special featured guest to join us, where we can then discuss and investigate topics raised by Intellect's recent book, Fighting for the Soul of General Practice, the Algorithm We'll See Now. The book is edited by Ru and Jens. It's a real tour de force, and it's available online from www.intellectbooks.com, as well as from all reputable retailers. But without further ado, Austin, it's great to have you on. Thanks so much for joining us today.
Thank you very much, James. Delighted to join the two of you. It's always a pleasure. Three of you. Sorry, I can't count.
Well, regardless of whether you can count or not, it would be wonderful if you just tell us a little bit about who you are.
So my name's Austin O Carroll. As I said, I actually originally, my first connection with medicine is I have thalidomide. So my mother took the medication thalidomide when she was pregnant. She just took 2 tablets, and I was born with a number of disabilities. So I spent a lot of my younger childhood in hospital. And I got my family. People often say, "Is that what influenced me to do medicine?" I say, I haven't a clue. I don't know. All I know is that I suppose I have a family who would be very much into volunteerism, and I was very much involved in volunteerism when I was young, in the Scouts, etc. And then when I was in college, I worked a lot with youth clubs and with different agencies for people with disabilities and people who were in areas of deprivation. And so medicine seemed the fit for me because I liked working in these communities, and I liked working with people in need. So I decided I wanted to do medicine. But when I first tried to do medicine, I was told I couldn't do medicine because my hands, I have an abnormality of my thumb, and I was told I wouldn't be able to take bloods, and because of my feet also I can't walk very long distances, they said I wouldn't be able to manage hospitals. So instead I did law for 2 years, and in my first year in law, Mary Robinson was my tutor, who subsequently became President of Ireland. And my second year in law, Mary McAleese was my tutor, who also became President of Ireland. So it's good to be a tutor of mine. And anyway, at that stage, I really hated medicine. I hated law. I discovered I hated law. And I actually, through fancying another girl who was doing medicine, and I never got to go out with her, but she did say to me, "Why don't you do medicine?" I decided to go to Mary McAleese, and she got me transferred into medicine a week later. And it all started there.
Well, and did she end up becoming the president of Ireland or any other?
No, unfortunately not. I didn't pass on the touch of the luck to her. No, I didn't.
Okay, well, I love that. It's a great story, and it's also quite a personal one. So it's always nice to hear how people make their way into medicine. And I think one of the things we're trying to do with this podcast is obviously sort of humanize general practice again, and sort of reacquire the soul of general practice in so many words. But today, I think, because of your background and some of the things that we've all talked about previously, and some of the topics that are raised, of course, in the Fight for the Soul of General Practice book, comes down to these notions of categorization. So I really wanted to talk to you and get your perspective on that. We've separately talked about some of the gains and losses of categorizing mental health conditions into diagnoses, which, I mean, to a layman, that sort of sounds like, what you would do, like the normal thing. But what are your thoughts on this? And can you maybe just explain to us, Austin, why you feel so strongly about this topic, and why you feel, what you feel maybe are some of the effects of labeling people? I'm sure there's both pros and cons to that, especially when it comes to mental health conditions. Would you mind just unpacking that topic a bit for us?
Yeah, I think categorization is used by doctors as a method of both power and also of trying to demonstrate they're scientific. I mean, it all goes back to originally to Linnaeus, who started categorizing biological specimens and basically created this concept that by categorization, that's what happens in science. And in medicine, we actually did use this categorization, and to great effect, because, for example, we started recognizing certain symptoms grouped together, and then we were able to connect them to certain pathogens. So we're able to find out that if you had very bad fevers and coughs and a cough and a chesty cough, and it went on for more than 2 weeks, could be the influenza virus. If you had severe diarrhea and it was almost and there's bloody diarrhea, could be typhoid or cholera. So we started categorizing, recognizing the causations of these things. So that has brought huge benefits to us in terms of managing physical health. The problem is that we started using this categorization process for almost categorizing everything. Almost everything in life is now becoming diseasified. So, I mean, the latest is obesity, sort of people have heavier weight. And so suddenly they've actually been recognized as disease in the States and the World Health Organization. And I know the RCPI has called for them to be recognized as a disease. And we start categorizing it as having specific signs and certain outcomes. And now we see that the UK health minister is talking about giving anti-obesity medication to people to get them off social welfare. I mean, they talk about medicalization, but they also talk about biopolitics, as in how medicine starts interfering in politics. And when you're starting using medical interventions to get people off social welfare, we are now into biopolitics. So if I go back to mental health, though, I think, which is the most obvious area where I think there's a deficit, the DSM is and as well as the World Health Organization ICD classification, they create these categories of mental illness. And these categories get subclassified and classified. And certain things are psychiatric diagnoses 1 minute. So homosexuality was a diagnosis back in the 60s. Gender dysphoria was a diagnosis. And then they get decategorized. Grief was a diagnosis at one stage, and then it became declassified, generalized grief. So that doesn't happen with cancer. Cancer is a disease. You don't have it as a thing, and then it's not a disease. And what they do is, in physical illness where you've got, say, cancer, you classify, we have to distinguish between an illness and a disease. An illness is the symptoms. And then also you may find signs. So if you have liver disease, you'll have a number of symptoms where you feel very unwell, but then you start to develop the symptom of jaundice, which is also a sign because you can see it. And then also a doctor will examine your stomach and they'll find an enlarged liver. So now we know that they've got the symptoms and signs, and we can then, if that person, we can do a biopsy of their liver and find there's disease in the liver. If that person dies, we can open up the liver and find the disease. So in physical medicine, the symptoms and signs lead you to locate the disease. They're sort of indicators of a disease process. In mental illness, symptoms are the actual diagnosis. There is no underlying pathological process. So when they make these categories, they categorize you as having, say, fatigue, tiredness, you're not taking pleasure in life, you're sleepless, you're not eating, and then they talk about signs about you dressing poorly. And you have to have various combinations of these, and they have to be there for so long, but they're basically just symptoms or behaviors. And if someone dies, if two people die and one has a significant diagnosis of psychiatric depression for the whole of their lives and the other never had depression, a pathologist would not be able to know the difference after which one had the depression and which one hadn't. And just in case people think there's pathology, actually most psychiatric illnesses don't appear in pathology books. I've looked through pathology books. There are some references in some pathology books, and other pathology books don't have any references to psychiatric diseases. So the second thing is that people often say, well, what about biological disorders? There's biological issues. Now, again, there's a problem about this is everything's biological. As I'm talking to you, there are biological processes happening. As I'm feeling hungry, there are biological processes happening. As I decide to go to sleep tonight, there's biological processes happening. If I feel happy, there are biological processes happening. Does that make any of these other things diseases? No. So, of course, there are biological processes that happen with mood. Now, the biological theory was based that, if we find there's a biological malfunction, we can fix this. So the classic one, originally for depression, it was noradrenaline and adrenaline. That was the original theory, that there was deficits in these particular, biochemical entities. And then we discovered the serotonin, and that became the serotonin hypothesis. And this really got launched when they discovered fluoxetine through Prozac. And remember, Prozac was going to be the answer to everything. Artists who were losing their ability to draw or losing their inspiration took it. Writers with writer's block took it. It was sports people where it was been used in women's magazines, were promoting it for almost everything, and it was seen as the absolute panacea almost to all forms of unhappiness. And then all these other serotonin antagonists started appearing, SSRIs, selective serotonin receptive inhibitors, and we got across this idea that people who have depression have this biochemical abnormality, and these SRIs plug in, they fix the biochemical abnormality, and hey, everything's fine. The problem was that when there was a legal case against a particular SSRI, querying whether it caused increased suicidality in the early 2000s, and the lawyers asked for a release of all the research, they discovered that a lot of the research that the companies had never been published. And of course, what they had done is they'd never published the studies that didn't find an impact from SSRIs. And when you combined the findings from the studies that weren't published and the findings that were, you found SSRIs may have had a mild to moderate effect in severe depression only, and had no effect beyond placebo in mild to moderate depression. And of course, the vast majority, and there's huge swathes of the population, we looked at our surgery, we found that 10% of our surgery were on SSRIs. So there's huge swathes of the population of on these. And in general practice, the vast majority are prescribed by general practitioners. And general practitioners only deal with mild to moderate depression. So these people are on a medication that has no better effect than placebo. Now, going back to the serotonin hypothesis, the serotonin hypothesis was based on the idea that SSRIs worked. Now that we know they don't work, in fact, a number of academics have come in and said the serotonin hypothesis now remains unproven. So there is no basis for the biological theory at the moment. There is supposition, but it has not been proven. And even if there was a biological basis, as I said, everything's biological. So to presume that that is a formation for a disease, I absolutely refute. Another thing just to refute is people say, well, you know, if you have a treatment for something, that means it must be a disease. Now, if I'm anxious before an exam and I take Valium, that'll relax me. That doesn't make it a disease. If I'm anxious because I have some big event next week and I'm terrified of speaking in public and I take Valium, it'll relax me. That doesn't make it a disease. Taking something because treatment doesn't make a disease. And this is to be clear. So in terms of mental illness, I think what happens is we've created these huge categories, and the problem about these categories is that when a person believes that they have a biochemical abnormality, then they actually believe that I am fated to be depressed. It's my fate. It's part of my essence. It's called essentialist stigma. It becomes part of your essence. So to give you an example, I had a close relative of mine who had broken up with someone, and they'd gone abroad and they were very down on themselves. They weren't getting up in the morning. They were ringing me up and really tearful, and they weren't doing their studies. They were falling behind in their studies. And then they rang me up and said, a friend of mine has said that I should go to a doctor or a GP. And I said, you're to go nowhere near a GP. Because I know if they went to a GP, they'd have been put on an antidepressant. And I said, you've got the blues. You broke up with someone, you're abroad, you've got the blues. Hang in there. You'll get better. And my fear was if they went to the GP and they took the SSRI, they would have got better anyway. And then they'd have thought, well, next time I'm depressed, there is something biochemically wrong with me. I need the SSRI. So you constantly need, and of course, just to say to you, you needn't doubt that the pharmaceutical companies are behind promoting this concept of biomedical disease and psychiatric as a disease, because they are making billions out of it. SSRIs are some of the biggest money raisers. And if people believe it's a disease, every time they get depressed, they're going to believe they think they need to get out of medication. I need to clarify at this stage, I'm not anti-medication. I'm not against using medication. I just think if you don't think something is a disease, you then have a much more broader ideas of what you could promote. So someone could come into me who feels very low, and I think they're depressed, and maybe we do need to go down medication route. Or someone comes in low, and I think they're lonely. Maybe we need to connect them up with some people in the community, some services that'll get them meeting people, some activities. Someone comes in and they're feeling low, and their family is in trouble because they're having rows with their husband, and I think this is relationship issues. Once you start thinking something is a disease, you only go down the medication route. Once you believe depression is multifactorial, much more complex, in fact, I prefer using concepts such as unhappiness, sadness, loneliness, and then I will use depression for certain people where I do think it suits. That's a rant.
Oh, Austin, that's brilliant. Thank you. I really appreciate the long but pragmatic answer. Thank you. That's really kind of like opened up my perspective on categorization, but not something I'm an expert in. So what I'm going to do is I'm going to hand over to Ru and Jens here, because I'm sure they have some questions about some of the things you've raised there. But as a basic overview, especially for any lay people who are listening, that was brilliant. Thank you very much for taking the time to explain your perspective on that. Ru, over to you.
A lot of what you said really resonates, Austin. And I think it's very problematic because on one hand, it encourages us to try to reduce complexity by simplistic kind of reductionist interventions, and it really curtails people's narrative. So I think part of our role, an important part of our role as GPs, is to enhance, you could call it creative capability or just agency of our patients. But if, like you say, they're firmly kind of the opinion that they've got a disease that they can't really get better, then it's limited. And it's also in a time pressured situation, it's so much easier just to say, well, go on, have this pill and that's going to make it all better, or a bit better, or as better as it can be. Have some talking therapy, but it's all framed in the context of the disease, which I think is really problematic. And also I think you've got to ask yourself the question, what good does it do? So sometimes it's really beneficial for people to have a diagnosis, but sometimes it can be really limiting. So there's gains and losses, and it's not as clear cut, I think, as it's presented.
No, I so absolutely agree with you. I think we're losing the richness of medical practice by simplifying things to my medical diseases. And I think people have to come, you have a choice early in your career. You're either going to just keep on the biomedical lens. And as you said, that does simplify things. It's not just for the patient, it simplifies it for the doctor. And as you said, it makes it much more time efficient, because you can just, this is the diagnosis, here's the medication. Whereas if you see this, things like loneliness, things like, I give an example. There's a patient came into me last week who I was seeing in the homeless sector. When she first came to me, she was fit all the symptoms of depression. She was about to give up her home and move into homeless services. She's only 22. She had got out of homelessness, but she's about to lapse back in. She said and as we chatted to her, it emerged that basically she had her rent had been going up, and she'd been working longer and longer shifts to keep up with the rent, and she was going to have to go out. Anyway, I met her 3 years ago, and I keep on saying I've used her example before, all I could offer her was hope. I could have offered her medication, but instead I said, I'll offer hope. And what I did was, we looked at what could she do to, well, first of all, hold it together for the moment, and then what were her capabilities. Actually, and you go back to capability theory, and actually she's a very smart kid. She's had a terrible, difficult, traumatic background, but a smart kid. We managed to get her into a better job where she got more pay, which is a carer's job. And last week she applied to go through on a grant to get into Trinity to do psychology, because we got her to meet another one of our patients who was homeless and has gone on to do psychology, and she's now decided she wants to do that. So I think medicine is much richer than just giving tablets. Tablets we do, and they have a place. But giving things like hope, giving things like just, I'm here for you, support. And then also using practical things like key workers, getting them to connect with social prescribers, get them to connect with counsellors, and using medication. But to me, the richness of my experience with her is I've had 3 years of meeting her and working through things, and we have a really good relationship. And I think that's the basis. And in our relationship, we've used tablets, we've used counselling, we've used key workers, we've used social prescribers, but it also was the relationship. So I always say is I get my trainees to go out to do the arts, because to me, medicine isn't just about learning a textbook about pills, it's about life, and you learn about life through the arts.
Relationships are a much better means of complexity reduction.
Absolutely.
Not the soft stuff. It's absolutely.
And that's what makes it such fun and such an interesting job. and because you can help people, but and that complexity makes it much more engaging. Yeah, I love it.
Jens, let me bring you in here, but before I
Yeah.
do, I'm just going to say, as a publisher focused on the arts and humanities and on increasingly on the medical profession and how it interacts with the arts, it makes me very happy to hear you say such things, Austin. I think that's really important, and I think just as a punter, as a non-medical professional in this conversation, it's also very reassuring to hear these different perspectives, because I feel you often think that you have a diagnosis, and then there's maybe a simple solution, and often it is a biomedical solution. And it's these podcasts and reading the books and the other materials around these topics has started helping me unpack this notion and come to a more holistic approach to my own health and well-being. So
Yeah.
it's really interesting to hear you deconstruct some of these notions that I think the general public certainly have around biomedical diagnoses and how these things kind of pan out.
First of all, just to clarify, lots of times we do simple biomedical things. There's simple solutions, so obviously that's part of it. But just a simple one about the arts, I often say, is you can have a group of doctors sitting around discussing a real life patient, and it'll be a really sad case, and you get some terrible cases, and they'll all be fine. And then that night they'll go to a totally fictional film or a totally fictional play, and they'll be blubbering in the aisles. And probably it's a good thing that they're not blubbering in the aisles inside at the thing. But the reason, as an educator, for to go with those arts is what makes you what actually helps you in medicine is that you can feel compassion from patient to patient, and that compassion is what keeps you going. And we all talk about when it goes compassion fatigue. That's when the job gets tough, and being able to work with real life emotions such as through the art, and as well as the themes they bring up. That's why I love working with the arts and humanities, and it makes it, I think, a much richer template for teaching doctors.
I would like to comment on the notion of the doctor assigning a diagnosis. Patient comes with a problem, doctor assigns a diagnosis, essentialist or not essentialist. I think that has recently changed considerably. Very often I see myself negotiating diagnosis where patients come with a fixed idea or notion that they have a certain diagnosis, bipolar disorder, very often now ADHD, certain conditions that need fixing, addressing, tinkering with. So it's very difficult. I see myself almost on the back foot of the protagonist of biomedical science to say, are there alternative ways of thinking about this condition? Does it all need to result in me prescribing? This whole infrastructure of prescriptions, medication reviews, supply problems, and that keeps me so busy. And very often I think I'm critical. Some people really need are really doing better with medicine. For others, it's so or so. For very anxious people, it's just an ongoing struggle because they read what the medication does. They get very anxious about the effects. They become hyper vigilant about what's going on. And I see both patient and I entrenched in this dance around what can I do? Something needs to be done. The promise of medicine that everything can be explained, treated, reduced to something that needs to be identified early and needs lifelong treatment.
So I absolutely agree with you. If I could take those two diagnoses, because I think they're two interesting and contrasting diagnoses. For example, someone who comes in with a diagnosis of bipolar, probably, my experience, most people don't come with that. Usually they're assigned that, generally by psychiatrists in my experience. And often with a genuine bipolar disorder, because I've often come across people who I'm not sure fit the pattern, but I do think medication makes a difference. And so I do, in those instances, say, lay out the pros of taking medication. And, there obviously are cons, so you have to put the pros and the cons. But I do seek to persuade people where I think it'll make a difference, particularly if they've had significant manic episodes, etc.
Yes, absolutely.
But the ADHD is the interesting one, because you're right. There's a lot of people coming with ADHD now. And I'll give you my perspective on ADHD. And I have a family member with ADHD and another relative with autistic spectrum disorder, both of which I see as neurodiversity. So to me, what happens is you have a narrow school system which expects kids to sit still and not move around and at desks. And you also have schools, people expect to be able to socialize together and interact with each other. And when kids don't fit into that system, such as my kid, didn't fit into that system, constantly moving around, needs to be shifting around, can't sit still, can't stay focused all the time on one thing, then what happens is that kid again gets labeled as the problem rather than the system. So to me, it's the system's the problem. It doesn't accommodate people with differences. So what I did learn, though, was because we were offered this label for our child. We originally said no, but then we're told, oh, you get all these services with it. You get supports, you get extra time, etc. So then we said, okay, so we'll take the supports. And we took the label. And what I now see the label is a signpost saying, this system doesn't work for me, so I need extra supports in the system. It doesn't mean anything about the child or the person. Yes, they are someone who likes to move around, shifts, finds it still, but that's the variety of human life. It doesn't say anything pathological about them. It just says they need that extra support to fit in the system. Now, if medication helps them support that, and I have looked at medication in terms of, and I know people have prescribed it, my experience is, though, people are much more fluid about how they use it. They use it to, like sometimes they just use it when they're studying or when they're doing exams. And I think that's actually, if that works for them, I'm not against it, as long as the side effect profile is not too significant. And what I find, most people who use it wisely don't take it all the time. They take it when they need it and then they stop taking it. For other people, but as I said, I'm not suggesting that everyone should take the medication. So I'm a low prescriber of the medication, but I'll always put it out as there as an option, because I'm not anti-medication. I'm a pragmatist. If something helps you, let it help you. But what I don't want you thinking is that there's something disordered about you that this medication's for. This is just a useful tool in a toolbox I have in front of you that may help you, but so may the supports in school, so may this, so may understanding that you have a difference that we're labeling and it's not a disorder or disease.
Very often patients come to see us and they're looking for an explanation for their suffering. They feel terrible and they're hurting, and they want us with our medical lens to find a reason for it. And I think the way that we tend to approach that is to sort of see, by asking a whole load of questions, which category do you fit into? But we've already talked today about how that's very artificial and kind of constructed in the first place. I think it would be quite radical, instead of sort of focusing on which category, to help them kind of rethink the story that they're telling about themselves and to make their own connections and their own meaning. And also, I think this notion that suffering should be banned and our job is to kind of stop everyone feeling sad all the time isn't helpful either, because I think human life is full of sadness. And, you know, I like what Austin said at the beginning. You've got the blues, you know, something bad's happened, you've reacted to it like that, but it doesn't mean that you're disordered. It doesn't mean you've got a disease which then you're stuck with. And I think it really alters your sense of yourself. I mean, Danielle Spencer writes about this beautifully, doesn't she, in Metagnosis. So I think we're complicit in something that we don't really realize we're doing.
Realize quite often what we are doing and are quite sophisticated about doing this. For example, when it comes to welfare, where entitlement for benefits is coupled to a diagnosis. Yes, ideologically it's not. It's on function and assets orientated, but in reality you need this diagnostic label to validate. And there's often an issue whether with the patient you say what is going well, what can you do, what are your assets, but to get some entitlement you have to focus on what you cannot do and what medication you're taking and which specialist has commented on what you can do and cannot do. I would say we are straddling this dilemma skillfully, but it's very, very, very difficult. where the process of categorization and establishing diagnoses is coupled or intertwined with processes of social administration. That makes it more complicated.
And I absolutely agree with both of you on this one. So I do think patients come looking for stories, and they develop their own rationale. So I had a cold because I was out I went out in the rain last week, so which has nothing to do with getting a cold. So they come up with their own because they have to find an explanation, and they sometimes find it hard when you say, "Well, there's no real explanation. You just got it, and we don't know how you got it, but it doesn't matter. We can manage it." So I do think they want explanations. I also think they want credibility, and they think if they have a diagnosis, they have credibility. So people who have long-term symptoms such as chronic pain, chronic fatigue, they feel that somehow they're disbelieved. And the reality is, because we have this biomedical model, doctors do. A lot of doctors do disbelieve them, are not disbelieve them, but are unsure how to react. And I think part of it is that we, as doctors, have bought into this idea that someone has to have a diagnosis for us to be able to treat them and to provide support. I don't care whether someone comes into me with a diagnosis of a condition that is a disease, I'll treat them. But if they come into me and they're suffering from pain or they're suffering from fatigue and they need my support, I will also treat them. And there's actually a lot of evidence to show that you can work with people with, say, chronic fatigue and work with the treatments and also know the prognosis, and same with chronic pain. You don't actually have to give this disease label or diagnostic label. You can still work with the actual symptom. And I also think if we as doctors learned that it's the response to suffering that we need to respond to, not to the disease diagnosis. Don't forget who also is not just the social welfare, by the way. Social welfare is linked to diagnosis. So is insurance in the US. You have to have a diagnosis. It doesn't have to be linked. That's a political decision. That could be decoupled.
Sometimes, when people want that credibility, getting a diagnosis can be a really double-edged sword. It can have like social meaning for us as medics that perhaps like the lay public isn't aware of. So I'd say like the most obvious one is personality disorder.
Yeah.
So I had a young girl recently saying to me, I really want this diagnosis. I think it explains everything that I'm going through. And I was saying to her, you really don't want it. You want it like a hole in the head. It has a real meaning for us as in healthcare, and you don't want to be associated with that meaning.
Yeah.
And I think I'm not going to necessarily mention lots of examples, but there are various disorders which patients may feel give them credibility, but are viewed, I think, very differently by medics.
Yeah.
Fibromyalgia, for example, personality disorder, and the story goes on and on and on. It's at the end of a letter stigmatizing, but if it's carefully negotiated with the patients, including feed-forward and feedback mechanisms, metagnosis, then it can be really helpful as a tool to understand what happened to you.
I did want to maybe bring us into a topic we've been skirting around a little bit, maybe around poverty and class and politics, and what the effects of these types of diagnoses, these types of stigmatizing people potentially, and how that connects with poverty and class, both maybe in the UK and further afield in places like the United States, because access to healthcare and things like that are obviously quite different in both those places.
Well, it also links in this, because if you look from the idea of poverty, when you biomedicalize something, you then say the fault is with the person. So
yes,
let's take obesity. Classic example. Once you start saying obesity is an individual disease, then the problem has the person has the disorder. You then take your eye off the fact that we promote obesogenic foods. Obesogenic foods are much cheaper. We have an obesogenic environment, and also the fact that people in poverty are more likely the ones to end up with higher rates of obesity because of the stress levels of being in poverty. And we know stress levels cause you to end up eating more and putting on weight. So once you biomedicalize something, you divert attention from the huge social causations. And again, the solutions of these are usually at a political level. And take, for example, personality disorder, which we've been talking about. I mean, personality disorder you're much more likely to get labeled a personality disorder if you came from an area of poverty. And I mean, I don't think personality disorder is a psychiatric valid diagnosis. I think it's actually, as Ru was saying, it's a diagnosis that doctors mean keep that person away from here. That's actually what it means. That's you're alluding to. And it's been shown that personality disorder is one of the most highly stigmatizing, and it has been used to exclude patients. So, but the fact that it's so associated with the impacts of poverty, and also specifically with trauma, means that by seeing it as an individual disorder, we are taking our eye off the fact that poverty causes trauma, which causes so many of our social ills, such as this high issues with people with personality disorders, such as drug addiction, such as homelessness. And then we as a society disown responsibility because it's an individual disease problem or disorder problem.
I mean, it's linked perhaps with, what Austin alluded to earlier about Wes Streeting proposing that people unemployed should be treated with the GLP-1 agonists, Ozempic, etc. It's not that per se. It's kind of just what lies behind that. It kind of allows you to not think about the social determinants, the reason why people got into that state in the first place, and sort of so it can be a bit distracting when you're thinking about root causes.
Absolutely. If someone is on social welfare and they're overweight and they want to use Ozempic, I have nothing a problem against that. But when you start saying that people who are overweight who are on social welfare should go on Ozempic so they can get back to the workforce, first of all, it's bad science. We don't know the long-term effects of Ozempic. Do they have to stay on Ozempic long-term? There are indications that they may have to. Second, so we don't know. I always love Iona Heath. She says she's a laggard when it comes to new medications. She waits for a number of years to see all the side effects reveal themselves. And I just think it is incredibly dangerous that we're talking about prescribing injections for people to get them off social welfare. This is 1984 on steroids. It's just horrific.
Yes, I mean, I totally concur with that. And again, living in the United States now, of course, you do see a lot of these things being ushered in without there being regulation or necessarily too many questions in place. So it's kind of a little scary. And of course, in certain states here, they've actually banned, I believe, the book 1984 now as well. So
serious?
I know. We have to fact check that, but I believe so. Yeah. So the ironies are running thin. But Jens, I'm sure you have something to add to this, to what Austin's been talking about, especially with regard to poverty in class and some of the situations you've probably seen yourself over the years. Do you have anything to add?
Lots and nothing at all, because poverty is the striking factor, and I link it to trauma, and that's my daily bread and butter, with pain, with sadness, with hopelessness, with agitation, with existential threat. But then my question is, how is my relationship with this? If I say yes, this is all a healthy response to unhealthy conditions, I need to be tactical. So there can be prescribing medication as part of the suffering, but that's not my main involvement. So my main involvement is more than that. It's helping with the appeals process. It's helping with socializing, thinking about pets, whatever. I need to be imaginative, compassionate, finding together with the patient what to do, knowing that these are the social determinants, and I cannot treat the social determinants with pharmacotherapy. Of course not, but pharmacotherapy is part of my armament.
And that one is like, I've been appointed as chair of a drugs task force recently, which is one of the reasons why I'm so busy at the moment. But it's really interesting because one of the things we have to look at is preventing drug use. And a lot of it has been traditionally around providing education to children, etc. And in fact, I started looking at the availability of sports facilities in the area that the drugs task force cover. And of course, there's much less sports fields and facilities in this area. And getting involved in sports is a way of avoiding drugs. There's also much less arts facilities in the area, and getting involved in arts is a way of avoiding drugs. And also getting involved in sports is a way of avoiding obesity in later life. So just to simplify this to simple biological processes that we have medication for is so dangerous. And
Yes.
I think ultimately could lead to an oppression of people. Going back to the double fuck is, we created the circumstances that cause you to be overweight, that cause you to be traumatized, and then we say it's your fault. And by the way, we're going to jab you too.
It's classic victim blaming for sure. To link in with this, I did want to just ask a little bit about politics and medical profession, and that's a huge topic, but just mentioning the Ozempic, and of course obviously we all experience the distrust of doctors, especially in say places like the United States during COVID, because of largely political tampering. And is this a new thing, and is this something we really need to be very concerned about, sort of the over politicization of drugs, of just biomedical issues and various topics that we've discussed today? Or is this part of a long, rich history of politics getting involved in things it shouldn't, and eroding trust in science, doctors, facts? And obviously these things are perhaps more prone these days to being questioned because of all the echo chambers and the effects of algorithms and mirror truths and all of that stuff that we're seeing on a daily basis through social media and various other ways of causing disinformation and spreading disinformation. But are these new trends, or is this kind of the same old business of politics getting involved with things that probably shouldn't?
Well, I think there's two things. One is I think there has always been misinformation involved in politics at a high level, but we haven't known about it. And I'm specifically talking about the pharmaceutical industry. I think no one has an understanding of the huge power they have in influencing government policy. We know that pharmaceutical industry has able to warp the way it produces results. We know that they have the committees that decide on guideline committees, the level of where the amount of people who are in guideline committees who have ties to the pharmaceutical industry has to be seen to be believed. I think I saw one article about 13 guideline committees, and every single one had over a half or over of the members linked to the pharmaceutical industry. We know the regulatory bodies. Many people of the FDA in the US, once they left the FDA, they became advisors to big pharmaceutical companies that they'd made decisions about when they were regulators. And we know that the FDA has had influence on the thing. And we know that in America, particularly, pharmaceutical companies give money to politicians. And I think there's been a huge amount of disinformation spread. So all this disinformation about that we need to take care of our health. Obviously, we need to take care of our health, but the way it's promoted has absolutely hugely helped the pharmaceutical industry. And I think that is a bit of disinformation that's been going on for 30, 40 years. So there's the second aspect you're talking about, which is about disinformation about things like COVID, anti-vax movements. That's always been existed, I think, in small areas. I do think social media has allowed this, explode into a much bigger movement as such. I think it's part of a bigger picture about truth and misinformation. This isn't just about medicine, this is about truth in general. And so it can be about COVID, it can be about immigrants eating the dogs, the story, the question absolutely exists, but I think it's a bigger question about truth and misinformation in general. I don't fully understand I don't know if any of you have any ideas on why people want to believe in these things. That's what I find intriguing, is what is attractive about believing in that all these vaccinations. It's almost like people like paranoid theories.
Yes, of course.
Yeah.
Because that's a reduction of complexity that makes it easier to navigate in the world. It's easier than being confused or doubtful and thinking and it ignores facts. So it's the having the simplifying narrative as the anchor to see the world.
Yeah.
Snake oil's always tasted sweet.
That's true.
To me recently. And I think I totally agree with you. And I feel like I read an article about flat earth theory debunking it, I should add. But no, it was about the attractive compulsion of people to be interested and fascinated, and then fall foul of such theories so easily. And it was similar to what you're saying. Not only does it make life, a bit like some would say, maybe religion and things like that, and more navigable and easier to understand, but it also gives you, if you're feeling disenfranchised and powerless, it gives you, I know something you don't. You need to wake up. You need to wake up, kind of thing. And it empowers people who have been disenfranchised from the conversation for a long time. And I think that's something that anyone who represents the intelligentsia or knowledge, education, we need to kind of put our hand up and find out ways to engage with people in a much more effective way, rather than disenfranchising them from education, information, and also just to remind people, that there are differences between primary and secondary sources, and everyone's entitled to an opinion, but it doesn't make that opinion fact. And I would really love us to see a return to the belief in science and trust in science, rather than eroding those core values.
I wish there was more kind of willingness or ability to embrace nuance and uncertainty, and understand that things don't have, usually, in as far as health goes, don't have linear kind of simple answers, and that trying to find them and crowbar, whether it's into a diagnosis or or treating unemployment with Ozempic, those kind of linear interventions don't usually work. So you're missing the point, and unfortunately, there isn't an easy solution a lot of the time.
I do think the concept of evidence-based medicine has to stand up and take some criticism. It's sort of like it's standing up there as in no one can touch this paragon of virtue. I'm a fan of evidence-based medicine, but it's limited in what it can research. I always go back to someone, I can't remember who quoted it, says, evidence-based medicine has not been evidentially shown to improve medicine. And I think what it is, I am quite happy to say that this evidence that this surgical intervention has been shown that actually it causes more deaths than lives. That's great. Get rid of that surgical intervention. But how do you show that evidence that someone who's lonely, that you by being there for them over a number of years helps? You can't do a study on that. So we start reducing medicine to these simplistic notions. Evidence-based medicine, I think, needs to review itself. And also, just one major kick in evidence-based medicine is that, for example, it allowed people like drug companies not publish research that showed no findings, and it knows that pharmaceutical companies are skewing the research, and it doesn't stand up and say anything about it. I'm for evidence-based medicine, but I think it has led to a simplification of the way we see our roles as doctors.
Thank you, Austin. That's a really important point, I think. And let us not forget the importance of peer review as well, and and sharing evidence-based research in things such as peer-reviewed journals, whether they be open access or otherwise. But we need to ensure access to this type of research.
Yeah, I'm thinking about Aileen Munro, the social worker, professor of social work, who did the Munro report about children safeguarding, and she said a lot about objectivity. She said a lot about evidence, and said research-informed practice, yes, but more with a critical approach to it rather than evidence-based. And I like that a lot.
Yeah, makes sense to me.
Well, we've gone around the houses a bit there today.
Yeah.
For me personally, of course, it makes for a very interesting conversation to link a few of these things together.
Yeah.
I know that the main topic was categorisation, but looking into poverty and politics and other things that have affected that or are involved in that conversation, I think it makes for an interesting topic in itself. I really, really want to thank you, Austin, for your insight and for giving us time again today. It's been wonderful to have you on the podcast. And of course, Ru and Jens, always an absolute pleasure to have both of you as my co-hosts here, steering this with some medical integrity and some knowledge beyond what I have at my disposal when it comes to some of these topics. So I really appreciate all three of you joining me today. Well, look, thank you each again for your time and for this wonderful discussion. Very thought-provoking and really important stuff. And I just urge all of our listeners to go out there and check out the work, much of which is available online from Austin, Jens, and Ru. And of course, you can take a look at the Fighting for the Soul of General Practice. The algorithm will see you now at www.intellectbooks.com, or from any decent bookshops out there. You can go and place an order for that one too. So thanks everyone for your time. Thanks for tuning in, and we'll see you next episode.
Okay.
Thank you.
Great. Thanks a million.
Thanks so much.